So this is for sure for Carla Abel, this check.
Yeah, I mean, I just duplicated it
Oh, okay.
and put in,
Interesting. Why did he send it? Cause he's usually down in Parker.
do you want the original?
Yeah.
Or, yeah, show me what, I mean, I can go look in his email.
So I just,
4890.
I just duplicated this.
Okay, I just
I
want to
didn't
make
put the
sure.
number, did I not read it right?
No, that's 4890. Okay,
Okay.
thanks.
Did you need one of these? Did you want to make a copy of this? To include?
Yeah, sure. Okay.
Uh,
It's always better to do that.
sorry, I could have made you one. I didn't even
Well,
think
I-
about that.
I can prove it.
Okay, well, I didn't even think about that. Oh, well, we got 144 holiday baskets spoken for.
Okay. Did you send any to them? Did you send any to Gabriella or?
I think all Madison has been doing it. Love it is the MailChimp thing. I think
Yeah,
I've got to do the next level of this,
yeah,
which is kind of the Eileen Doherty plead.
yeah.
Plus, I've probably got to have, I probably got to think about specific people and find last year's list and,
Yeah, maybe I can,
you know what I'm saying?
yeah, exactly.
Um,
Oh, it takes much more than you think.
well, and Mrs. checked out. So,
Yeah.
you know, didn't check in too good to start with. Good afternoon, everyone. I am Eileen Doherty, and I'm the director of the Colorado Gerontological Society. And as part of our Wednesday lunch and learn today, it occurred to me at some point that sometimes we talk about a lot of the different benefits that the different parts of Medicare have. And we may not always understand either how we get to those decisions or what kinds of services are involved. So my goal today is to spend a little bit of time just to help people understand in 3 different parts of the Medicare Part A benefit: skilled rehab, home care, and hospice, what's involved with that, and what we can expect in the way of services and costs. So this gentleman feels like many of you, I'm sure, as we look at what really is going on with Medicare and all of sort of the complications. Just quickly to review, Medicare has 4 parts: A, B, C, and D. And we are only going to look at A today. And we are specifically going to look at these 3 pieces of Part A, which is the skilled rehab benefit, the home health benefit, and the hospice benefit. So therapy basically is one of the Part A benefits, and there are basically a couple of things involved in therapy. Its goal is to evaluate and treat injuries and diseases that change your ability to function. And then after we have evaluated that, our goal is basically to improve or maintain either current function or slow down decline related to that functioning. There is a skilled nursing piece as well that goes with Medicare Part A, and we'll spend a little bit of time on that, but mostly we're going to look at rehab and therapy. So why would one get short-term rehab? Primarily for these different types of conditions. So if you had a stroke, there's a number of things that we can do with short-term rehab. If you have any paralysis in an arm or a leg or a hand, if you have cognitive issues, if you have swallowing issues, if you have energy or strengthening issues. So there's a lot of things that rehab can do if you are post-stroke and recovering. The second thing that it makes a lot of sense for is knee or hip replacement. Again, we not only spend a lot of money giving you new joints or new metal or new parts, but then we want you to get active again and be able to use them so that you regain your mobility and your functioning. Cardiac or respiratory ailments. This is following, say, a heart attack or a stent or any other kind of heart issues. Again, we want you to be able to be mobile. We want you to be able to walk around. We want you to regain your lung functions. So we're not, if a part of your heart is no longer functioning, this type of therapy may not replace that, but maybe we can get you back up and walking and moving around. Multiple sclerosis, Parkinson's, spinal cord injuries. These are all things that happen to people, which again, reduce or limit our mobility and limit our energy levels, limit our fine motor skills. Some of them limit our large motor skills. So again, therapy can help with that. Hip fractures is similar to hip replacements. We want you up walking around. We want you moving. We want you independent. And post-ventilator care, again, because of the nature of being on a ventilator, many people lose a lot of strength and a lot of ability to be independent. So in a skilled nursing facility or a long-term care setting, basically what we're looking at is what type of a facility might we get services. So in a skilled nursing facility, many of them will either have the entire building or a unit within the building, and they specialize in Medicare rehab. They specialize in helping people who have a 3-day hospital stay, 3 midnights, and are eligible then for up to 100 days of intensive therapy services in the skilled rehab facility. Back when I was first in the business of working with older adults, Medicare would, our recovery, if you will, from whatever acute illness we were working with would be done in a hospital. It was not uncommon for people to be in the hospital for 10 days to 2 to 3 weeks, 25 or 30 years ago, maybe 35 years ago. But as the price of hospitalization has increased, we see more people now being discharged to skilled nursing facilities for skilled rehab, and that happening in a less costly setting. The acute care setting, basically also, they are under a lot of pressure, if you will, to not have individuals re-hospitalized within 30 days of discharge for the same diagnoses. So many of them have relationships and risk relationships with facilities. And the goal then is for the nursing home to serve as an extension of that acute care hospital so that you do not have to go back to the hospital. And with rehab, hopefully that will be the case. In long-term care settings, the other thing that we're really looking for is wanting to make sure that you are able to do your own activities of daily living in addition to strengthening. There are therapy caps. So for 2023, you can get a total of $2,230 worth of physical therapy and speech and language therapy, and then an additional $2,230 of occupational therapy services. So sometimes you will hear that you have run out of your skilled Part A therapy allotment or cap. You've reached that cap. There are no caps when those therapies are a Part B service, but they are when they are a Part A service. So how do we get to this amount of money? So Medicare has this thing which they call the 8-minute rule. So Medicare basically allows your therapist to bill outpatient services in 8-minute increments. So if the therapist sees you for 15 minutes, they can bill even if they only saw you for 8 minutes. So sometimes people aren't able to endure a full 15-minute or 30-minute therapy session. So if the therapist has worked with you for a minimum of 8 minutes, then they can bill for that 15-minute time frame. The amount that is billed is all over the lot. That is determined by the facility that you are in, and so we don't really necessarily know how many therapy sessions you could get because that is dependent on who is providing the therapy. Therapy does have to be provided by approved practitioners. So it can be provided by your doc, a nurse practitioner, or a physician assistant. It could be provided by physical or occupational therapists, speech language pathologists, and any assistants, such as like graduate students who are training or working with a licensed individual. So one of the billable events, if you will, on this 8 minutes is the initial evaluation. So what they are looking at evaluating is what is your functional ability based on what your current problem or complaint is. This is usually done by a physical or an occupational therapist, often then with a referral to a speech language pathologist, although sometimes they will do the initial evaluations as well. Part of what they're looking for in this initial evaluation is how severe is the problem and what impact is it having on you and other systems within your body. So, for example, if you are having a swallowing problem, is that related then to a cognitive deficit? Is it related to a paralysis in your esophagus? Is it related to your speech? Because we all get saliva in our mouth when we're talking. And if we get too much saliva, then we may have speech problems if we're not able to swallow the saliva. So those are the kinds of things that they are looking for. And then they're also trying to figure out, was this a pre-existing condition or was this something that is new? Because again, that tells them what type of therapy that they should be looking at and what their approaches should be. Other things that they're looking at are things like pain, back pain, neck pain, shoulder pain, wherever there might be pain that you would be experiencing. Now, Medicare has this kind of convoluted definition of medical necessity. And as you probably know from all of the sessions that we have done over the years, the Medicare rules are part of the Social Security Administration and that enabling legislation. So the definition that Social Security and Medicare use of medical necessity says that no Medicare payment shall be made for expenses incurred for items or services which are not reasonable and necessary for the diagnoses, how we get to the initial evaluation, or treatment of illness or injury, or to improve the functioning of a malformed body member. So it's kind of a convoluted definition, but basically the implication is that there is some part, whether it's your brain, whether it's your arm, whether it's your leg, that is not working correctly. So medical necessity then for therapy to be able to bill, the patient has to have the potential to improve or is expected to improve or gain maximum improvement if they do participate in therapy. So if it is reasonable and predictable over a period of time that somebody would be able to improve, then that is one of the criteria that is used for medical necessity. The other thing that becomes important in medical necessity is the extent or the amount of improvement that the individual makes based on the therapy that is provided. And then another thing they evaluate is whether or not you are able to tolerate, if you will, the amount of therapy that it would take to get you to that higher level of functioning. The other thing is that therapy is not required to affect improvement or restoration of function if a patient suffers a transient and easily reversible loss or reduction in function, which could be expected to improve spontaneously as the patient generally resumes normal activities. So if you have been at home in bed with pneumonia, say for 2 or 3 weeks, and as you are recovering, if you are just generally weak, but you're not like at a level where you're at a level where if you just get up and exercise, you will get better, then therapy would not be provided. So the definition is that services are necessary to improve a patient's current condition, to maintain the current condition, or to prevent or slow further deterioration of the condition. So not only does it have to meet medical necessity, but then in addition to that, the therapy has to be able to show improvement. Therapy is warranted, if you will, or needed when skills of the therapist are necessary to safely and effectively come to provide a therapy service with the goal of improving either the impairment or the functional limitation. Additionally, the services have to be complex and sophisticated enough that I can't just do them on my own, that it requires a skilled therapist to be able to teach me, if you will, or have me do those exercises, because if I did them on my own, I would be unsafe. The second piece then is we want to get to a maintenance program where basically the therapist helps us get to this maximum functioning, and with the either exercises or activities that they are having us perform, that we can either do them on our own, or they get us to a level where we are able to function because we have had the necessary healing or strengthening. So at maintenance, basically, we're going into, if you will, kind of the third level of therapy, the first level being evaluation, the second level then being kind of the intensive therapy, and then the third level being maintenance, which is where we want to stay. And so we can get therapy services basically that then help us stay, if you will, at that level. And the therapist then looks at discharging us. We can be then discharged as either the patient or a caregiver is instructed on how to continue to maintain the function or that we have lost, and to manage that. And then they can do reevaluations just to make sure that everything is going perfectly the way it was intended to do. So skilled services, then what happens when you reach maintenance is that you or someone who is involved with your care is then the care or the therapy is turned over to them. And at that point, then no coverage is provided by Medicare. There is sometimes conversations about if people have limited cognition, are we able to provide them with therapy? And the answer to that question is very often yes. If there is or can be demonstrated that even though the individual might not be able to comprehend instructions or follow directions or remember the skills, if they can be supported and if it improves that individual's functioning and their ability to, again, maintain a certain level of independence, then that therapy can continue to be provided. And here we're often looking at things like balance, strengthening, helping people sit properly in a seat or a wheelchair, getting people to help learn how to transfer from a chair to a toilet or a bed. And again, it's helping them to walk through, or making sure that the person helping them understands how to manage that, and giving them the strength and the ability to follow simple instructions. So we can get a reevaluation, and I find myself often suggesting, if you will, that somebody who may have been in therapy a year or two ago, or even 6 months ago, as I see their condition maybe changing, or some other situation has exacerbated what is happening. So for example, if somebody had a hip replacement and they had reached their maintenance level, and now they were having difficulty, if you will, because they recently had a major cold or bronchitis, and now they've lost a lot of lung function, I often will suggest that they contact their doctor for a evaluation by a therapist, so that the therapist can come out and determine whether or not, based on their clinical findings, that some more intervention would be able to slow any further decline, or maybe even improve their current situation. So let's move now to home health care. This is care, and it can include physical, occupational, speech therapy in the home, or in an assisted living usually, or sometimes it's actually delivered in a long-term care facility as well. Home health care then is 100% paid for, as is rehab for the first days 1 through 20 in a skilled rehab facility. Days 21 through 100 have a copay, and that's a little over $200 for 2024. In addition to skilled nursing and therapy services in the home setting, you can also be eligible for medical social work services. You can sometimes qualify for limited home health aid services, and you also can get durable medical equipment. But there you do have to pay the 20%, or Medicaid will pay it, or if you have a Medicare supplement, that will pay it. So to be eligible for home health, the very first thing you need is a doctor's order. The second thing is that you have to be homebound. You can't just be somebody who's up moving around. You have to meet certain criteria to be homebound. You have to need intermittent skilled nursing and therapy, so you can't need 24-hour care. And it has to be delivered by a Medicare certified home health agency. So the definition of homebound is often been challenged, and I can point to a number of home care agencies over the years in the Colorado market who have been sanctioned, if you will, by Medicare, who have had to close their doors, who have basically engaged in Medicare fraud. Oftentimes when that happens, it's because they do not accept, if you will, the literal definition of what homebound is. So homebound happens when leaving the home is not recommended. The condition keeps the individual from leaving the home without help, such as using a wheelchair or a walker, and it has to be extremely taxing and take an extreme amount of effort, if you will, to leave the home. So, for example, I have a lady who, when we have to take her to the doctor, it basically requires 2 or 3 people to be around her, because to get her in the car, she has to pivot from her wheelchair, and then she uses the door for support. So someone has to hold the door, and it has to be a pretty strong individual to make sure that the door doesn't slam. And then she has to pivot to a point where she can get her bottom on the chair. And then eventually, sometimes she's able to move her legs into the car of her own doing. And sometimes she will need help with somebody to lift those legs up a bit so that she can get them over and in below the, or, in the car. The other thing in terms of leaving and taking considerable and taxing effort is that the person really leaves for very short and infrequent reasons, such as going to church or to an adult day program, but just going to Thanksgiving dinner is not going to cut it. So when do you receive services in your home from skilled nursing or therapy? Is basically following a 3-day hospitalization. Other reasons that you could get a Part B benefit might be if you had a new or exacerbated diagnosis. This could also happen while you're in the hospital. They've changed your meds in the last 60 days, or you've had new meds in the last 30 days, or your primary care provider basically knows that you are having declining cognitive functioning. So those are all reasons why you could get skilled care in your own home. The nursing care then specifically is looking at things like med administration, wound care, catheter care, IV therapy, nutrition support, diabetic care. That's the kind of support, if you will, that is provided under Medicare Part A and sometimes under Part B. You can get these services additionally if you have had a very significant decline in your functional status, whether that's speech or ambulation, strength, endurance, if you had a recent fall or a fracture or stroke, and if there is a need to have a program so that you can continue to basically live in your own home and function as independently as possible. The kinds of services that you can get for Medicare home care is on the home health side. This is the skilled services, and that's where you're getting physical and occupational therapy, you're getting medication set up, you're getting teaching, you might be getting injections. Sometimes they'll do labs like blood work. You get wound care. If you are eligible for Medicare home health care, you can also, as part of your Part A benefit, get a little bit of help from a home health aide. And these are things like meal prep, house cleaning, getting dressed or grooming, ambulation, falls, those kinds of things. This again is limited, though, this home care to only as long as you get the skilled services, either from therapy or from nursing. Medicare will cover if you are under the care of a doctor and you have a care plan. You need the intermittent care or services, and it is approved by Medicare and you're homebound. If you need 24-hour-a-day cover or care, you need just general overall help with activities of daily living, or instrumental daily activities of daily living like shopping and cleaning, or meal delivery. Those are not services that Medicare will cover. Now, if you are in a Medicare Advantage program, some of the Medicare Advantage programs may provide a little higher level of care or of services for some of these things. For example, several of them have a program where you might be able to get 2 weeks of meals delivered following a hospitalization or a nursing home placement. Medicare is basic, or home care is paid for by Medicare if you meet their criteria. Medicaid is a little less strict, and they tend, if you are on Medicaid, to cover more things like the activities of daily living and the instrumental activities of daily living, leaving the need for skilled services then to be delivered by skilled staff and paid for by Medicare. Some people who need assistance with activities of daily living, and if they are eligible for veterans benefits, may also then be able to get a payment through aid and attendance, and then they can use that for home care. And obviously, always we can private pay for these kinds of services. So just a quick summary. The goal of home care basically is to help you recover from an illness, a surgery, or an injury, or to manage a chronic medical condition. People who are homebound, the doctor writes a letter, writes a certification, and the person only needs intermittent care, is eligible. It's provided by skilled therapists who work for a licensed facility. And then there's different payers depending on what your coverage is. The care can be provided to the patient, always has to be to the patient, but there is some opportunity for education for caregivers. Basic things like skilled services of nursing, therapies, social work services, as well as some limited help with activities of daily living. Has to occur basically in your home or in an assisted living. The home health team is available 24/7. And as long as the doctor certifies that that it is medically necessary, you can continue to receive the services. So now let's turn ourselves a little bit to hospice. So to be eligible for hospice, your doctor has to certify that you have a terminal illness and that you have 6 months or less to live if the disease runs its normal course. Additionally, you have made the decision that you want to stop all curative treatment. And you really want to just focus on any kind of treatment that provides you comfort and quality of care. And your provider has to be certified by Medicare or Medicaid. Hospice services come to you with a very rich team of people. We have doctors and volunteers, nurses, therapists, aides, grief counselors, social workers, spiritual counselors. So we have this whole really big team. When my aunt was on hospice, because she had dementia, I really felt like we should have had that team of people working with her 2 years before that, because then she could have really benefited from the support of all of these different groups or different professionals. So the hospice will have its own medical director who will certify that you are in a terminal state, and he or she has to participate in the development of the plan of care. Another member of the hospice team is the attending physician. This oftentimes is the person's primary care physician. Sometimes the primary care physician is no longer involved, and sometimes they are. We have the registered nurses whose responsibility it is to basically do symptom management and to provide whatever comfort care is warranted based on the individual's needs. They also coordinate with the patient and family to make sure that all of the services are available. The hospice aide is the person who comes in to help with bathing, help with changing clothes, maybe helps a little bit with laundry, but not usually, may help with feeding, just personally trying to keep the older adult, or not necessarily the older adult, but the hospice patient really as comfortable as possible. Volunteers oftentimes will come to provide friendship and support. They're often there for just companionship, just sit maybe sometimes and be quiet or watch a television program or whatever. Usually comes with some type of spiritual support. This could be from a chaplain. It can be from somebody with an ecumenical background, can be someone from your own choice of religion. But again, they're there to provide that spiritual support. The social worker is frequently involved to make sure that if there are any community resources that are needed, as well as to provide any type of emotional or psychosocial support. And again, we're not necessarily looking at intensive therapy, psychiatric or psychotherapy, but really to just help the person work through their feelings, their grief, their anger, their loss, to get to a place of feeling okay about their decision. And then we have supportive therapy, and this is often nutritional counseling or support. This could be like Ensure, could be just things, again, that can make your quality of life better. So a lot of different people can qualify for hospice services. The one we tend to think of most frequently is victims of cancer. And that's certainly, if I am remembering the statistics correctly, by far is the most frequent referral by the healthcare community to hospice services. But you could also be referred for chronic obstructive pulmonary disease, congestive heart failure, AIDS, end-stage kidney disease, Parkinson's and other neurological disorders, and for end-stage dementia care as well. So this hospice team, I apologize that this is pretty small, but again, each person in the hospice team has their own required, if you will, or responsibilities. So we kind of went through those a few minutes ago, but really everybody has their role and their responsibility, and that is what makes the interdisciplinary team work. Usually the nurse is the lead person, if you will, in coordinating and delivering care. So the nurse is usually the person that does the evaluations for continued services. They're the ones who get called if there's a crisis. They're the ones who then work with the doctor to adjust medications or other therapies to manage the symptoms. This is just another depiction, if you will, of the hospice benefit and all of the different services that Medicare will pay for. So Medicare pays the hospice a daily per diem rate. And based on that rate, they then are required to provide all of these services out of that daily amount. So sometimes you will hear people say that they do not get as many services as they might like, but that's because the hospice is trying to be more efficient and not giving it or approving as many services, maybe as you think you might be entitled to. Medicare for hospice patients does not cover things like co-pays for prescriptions. So those of you who have been joining on some of the other presentations, there is a $5 copay for all prescriptions under the hospice benefit. If you use the inpatient respite services, there's a 5% out-of-pocket expense as well. If you, so people can stop their hospice care at any time, and they can go either in or out if they are eligible. Their medications related to conditions other than their terminal illness would be covered under their Medicare Part D benefit. So oftentimes, we don't usually recommend that you drop your Part B or your Part D services because you may need those. Example, many years ago, I had a volunteer whose mother was on hospice, and we didn't think she was going to be with us very long. But unfortunately, she was in a skilled nursing facility and she fell and broke a hip. And she had so much pain with the hip, but that's not a Medicare hospice covered service. So fortunately, we had kept her Medicare Part B, and we were able then to have that hip reset, not basically by putting her under or putting any additional pins or anything in, but we were able to get her out of the excruciating pain that she was in because of the way that that hip was dislocated. Medicare never pays, or hospice never pays for room and board, and they don't pay for 24-hour or 24/7 care unless you're in an inpatient facility, and that usually is very limited, usually for crisis. And then once you are stabilized, either you can go back home, or you would go to a skilled rehab facility, not a rehab, skilled nursing facility, where you might then be able to get more care. If the care isn't pre-approved, then and delivered by someone from the hospice team, it also will not be paid for. So how do we stay on hospice? How do we continue to get hospice services? So this is kind of a graphic that one of the hospices used to begin to help us think about what does a decline in condition look like. So if the individual does not decline in terms of their physical functioning, then you are no longer able to stay on hospice. So at the very high level, then if you're able to carry on normal work and normal activity, and you don't need any special care, then you would not be eligible for hospice services. If you have, and that's where they would give you, say, 100 points or the top number of points. And then if you're able to carry on normal activity with some symptoms, as we go down this scale, what we see is basically the individual being less able to be independent. So at 70, the individual can still care for themselves, but they're not able to do their normal activity or their active chores or whatever it is that they're doing. And this might be, that they are no longer able to cook 3 meals a day. They're not able to be up and out without, 2 or 3 naps a day. As we go down and we get to a 50 and a 40, we start to see that the individual is needing more care and more frequently. By the time we get to a 40, we're maybe sometimes requiring special care. This might be a hospital bed. It might be help with breathing devices. It might be help getting in and out of bed. But the disease is basically progressing, and by the time we get to the bottom, we're very sick. We may actually be admitted to a hospital, or we are certainly getting very active supportive therapy or treatments. And then at the end, right before we pass away, basically the disease, and we're losing most of our ability to breathe. Our lungs are not working, our kidneys aren't working, our liver is not working. So basically our disease, our body organs are shutting down. This is a grid that I thought might be helpful to some of you, because we're going to look at it on the next slide at how it relates to dementia. So this puts, if you will, or categorizes dementia into 7 different stages. So you've got 1, normal aging, 2, mild cognitive impairment, a little bit of functional deficits, but it's very subjective. As we move to mild dementia, we see some interference with complex tasks. So we might see people who are having some difficulty remembering names. They're needing more cueing. They're needing more, outside support. By the time we get to mild to moderate, mild dementia, we're really starting to see that the person needs help with paying bills and cooking and cleaning and all of those kinds of things. And then as we move into 5 and 6, we're starting to see that we're needing help with bathing. We're needing help with putting on our clothes, selecting our clothes, going to the toilet. And then when we get down to severe dementia or 7, we're down to someone is barely able to speak. They usually have very limited ability to walk or sit up or smile or hold their head up. So how does that kind of relate, if you will, to being able to use hospice services for dementia? So again, this FAST form is sometimes used as a way, again, to determine functional assessment for dementia patients. So a 1 if you have no difficulty. And then as we go down here, again, we give somebody a 4 if they are having difficulty with paying bills, cooking, or whatever. 5, then we start to see that their inability to care for themselves. And then 6, basically over the past several weeks, they have experienced more and more difficulty with things like dressing, bathing, toileting. And then by the time we get to 7, this is the level where we're able to bring in hospice services, if you will. So when we are starting to have limited speech, we don't necessarily have command of a lot of words. We're using a lot more signs, pointing. Sometimes we can make our needs known, sometimes not. We may or may not be able to walk or sit, and we've lost our ability to smile and sort of hold our head up independently. So we're spending a lot of time, if you will, with pillows, laying down, making sure there's no skin breakdown. When we reach that level, then we've may be eligible for hospice. So if we're in stage 7, that is one of the criteria. And basically stage 7 just really reconfirms, if you will, what we just covered with the inability to dress and walk and bathe and toilet, as well as speak. But then they add another criteria in the last 12 months, and that is we've had aspiration pneumonia, we've had a urinary tract infection, we've had septicemia, which is blood poisoning, a stage 3 or 4 ulcer. We've had ongoing fevers that we just can't get rid of. We have significant weight loss. We can't maintain our fluid or calorie intake. So that's the kind of thing then that if we're experiencing those types of conditions and we have dementia, then we can also qualify for hospice care. So Medicare, Medicaid also cover hospice care. Medicare, as we know, will pay for the hospice care, the services, the nursing, social work, whatever, as well as respite care and prescriptions. And Medicaid will do the same. Now, I thought it might make sense to look for a few minutes at palliative care, because sometimes palliative care gets confused, if you will, with hospice care. And there is a difference. So palliative care is basically a specialized approach to caring for people who have life-threatening diseases. It shares, if you will, the same purpose as hospice care for things like relieving pain, managing symptoms, and maintaining discomfort. We'll also try to provide emotional and mental health support and spiritual supports to empower us or find closure in our lives. So this is the difference, if you will, between hospice and palliative care. So on hospice, we have a terminal diagnosis. On palliative care, we have a serious chronic disease, but it's not necessarily terminal at the moment. Hospice, we get at the last 6 months of our lives. Palliative care, we can get anytime we might qualify. Both of them look at treating pain, but in palliative care, we're still doing curative treatment. So we might still be getting chemotherapy, or we might still be getting all of our heart medications and our diabetic medications. Both of them usually take place in the home, and both of them work with a multidisciplinary team. So this just basically looks at the where there is overlap as well as where there is difference. So on the palliative side, we're doing it in conjunction with other care, and it's anytime during the illness, and we're really focusing on end of life. In hospice care, we're looking at comfort care. The care is no longer life prolonging, and we are really preparing for end of life and death. Both of them, in their shared responsibilities, look at symptom management and providing physical, emotional, and spiritual support. What they have in common then is palliative care is paid for by insurance or self. There is a little bit that is paid for by or can be paid for by Medicare under some circumstances. Palliative care you can get at any point in time. Hospice, we do have a terminal diagnosis, and it usually happens either in the hospital or sometimes at home. Hospice services usually happen either at the home or an assisted living or a skilled nursing facility. Again, they're really looking at comfort care and reducing stress. They focus a lot on symptom relief as well. This just tells us who pays for hospice care and palliative care, and most palliative care is billed under your Medicare Part B. benefit, your hospice care is billed under Medicare Part A. And this is just a quick summary, if you will, of acute care being what you get in the hospital, palliative care, and hospice care. So acute care and palliative care are actually a therapeutic approach to delivering care. Hospice, on the other hand, is a program, and it then uses palliative care as one of the types of care that it delivers. Acute care is usually curative. Palliative care, then we're still, again, we're removing or trying to do symptom management, but we're also still engaging in curative care. Insurance and Medicare tend to pay for all of them as long as we are in licensed facilities. Acute care usually happens in the doctor's office or in the hospital. Palliative and hospice care happen at home or sometimes in a skilled facility. We have a different goal in each one. One is to cure, the other is to provide comfort. Theoretically, the diagnosis in acute care is that it's curable. In palliative care, it's terminal, but we're not estimating when we will see the end of life. So we don't have to have a certification that the person will pass away within 6 months. And the caregiver in the acute care setting is a doctor or a nurse. In palliative, it's a team, physician, nurse, and family. And most of the time, the lead caregiver in hospice, as I said, is the nurse. This is just, again, another way of looking at palliative care versus end-of-life care versus terminal care, with the two blue ones primarily reflecting, if you will, hospice care. And as we go across the hospice continuum, we're more looking at terminal care with a very short period of time to live. So that concludes our comments, if you will, about the services and how skilled rehab, home care, and hospice/palliative care work under the Medicare benefit. I'll just do a brief overview of the Society's programming. We do try to work a little bit in the areas of the social determinants of care of health, with vision, hearing, dental services, some mental health counseling, telephone buddies, advanced care planning. We have a housing and home care locator where you can get a list of all of the licensed facilities in Colorado by pushing on the blue button on our website. And then you can get benefits, counseling, Medicare, and Medicaid as well. Other things that we do is in the education and advocacy space. We do the Salute to Seniors, as well as we'll be publishing the Senior Resource Guidebook. It is off at the printer, should be available in libraries prior to Thanksgiving, or at least it should be out of our shop. Medicare Monday, we still have one more week of those events to do. So our last Medicare Monday events will be next Monday, the 13th, I believe it is, or 12th or 13th of November. So we'll continue to have at least a little bit more of that available. If anybody needs any prescription drug support, we can also provide that through December the 7th. I am going to, if I can figure out how to do this, launch this poll. If you would just take a couple of minutes and answer a couple of questions. That just helps me. I should have been doing this, but I kind of forgot. And so while you guys are answering these questions, I am going to see if there are any questions in the chat. So thank you for joining us today. And at the moment, I see that there are no questions in the chat. So if anybody has any questions that you would like to ask while people and yourself are finishing the polls, that would be wonderful. Nancy, if you had a question, I did not hear you.
Could that poll be put up again, please?
Um,
I'm not able to.
make it work. It should still be there. I can see though if I can, I don't know what happens if I launch it again, but I could try. Might mess it up. I'm not sure what happens.
When I click submit, it doesn't do anything. It just sits there.
Oh, well, that's just helpful. Or the lack thereof.
Submit won't submit.
It won't submit. Then it's probably me and I did something wrong. So thank you all for trying. But it's probably not going to work. And somebody asked if I would be sending the slides, and yes, I will plan to send the slides and the recording tomorrow, or the link to the recording.
Okay.
Okay, well, if it won't submit, thank you for trying. Like I said, I probably did something wrong, and I will check with my young guru staff members and ask them what I did wrong. So thank you for joining us, and we'll see you soon.
Okay. Have a good one.
Oh, somebody says they were able to submit, so I don't know. So you give it one more good try. And if it doesn't work, don't worry about it.
It's all yes for me, Eileen.
You were able to submit.
No, but it's all yes if you want.
Oh, yours, oh, yes, if I need to, okay. If I need to forge your responses to keep the
Don't worry about it.
keep the funding people happy.
That's right.
Okay. Well, sometimes they ask for this. So anyway, thank you all for joining us, and I'll see you soon. Bye-bye.
Right. Bye-bye, Eileen.
Bye. Thank you.
Bye.